Okay, so pick up from where we ended last week. So under management, we'll break down from mild and then moderate to severe and then severe head injuries. Most people with mild traumatic brain injury, or also known as a concussion, are sent home simply because they do not meet inpatient criteria. But it's important to give specific instructions to the patient and the family. We typically require a family member to be there upon discharge because, of course, if the patient is the one given the instructions, will they know if they're confused? Okay, so therefore it has to be a family member. So a contusion, this is under mild TBI, also again known as concussion. Now, for intracranial hemorrhage, this obviously is under moderate. As to whether it's moderate or severe depends on the patient's symptoms. Okay? Now, there's a difference really in the because there's seldom any loss of consciousness in a concussion. I'm not saying there's none, but typically a concussion or mild TBI, the patient does not sustain any loss of consciousness. Now, the severity of the TBI, whether the injury is moderate or severe, one category is based on the length of the loss of consciousness. How long was the patient out? Okay, so if it's less than 30 minutes, that's usually classified as moderate. Anything over 30 minutes, that's already severe. We already discussed the hematomas last week. So again, does not matter which layer of the meninges it is. Any hematoma is a space-occupying lesion and therefore will cause increased ICP. Now, the important thing about mild TBI, as I mentioned earlier, since these patients are again discharged because they do not meet inpatient criteria, I mean, what are you admitting them for? You can't say, oh, we're admitting them for observation. Okay, it doesn't meet the Medicare, Medicaid requirements for observation. Okay, so the patient's condition does not warrant any reimbursable manifestations. So therefore, a patient is sent home with specific instructions. Now, the instructions are the following, meaning the patient has manifestations of a concussion, but again, they're not serious enough to warrant an admission. Now, if you look at the signs and symptoms that will require the patient to be brought back to the ER or calling 911 are the following. If the patient's level of consciousness decreases, now this could be in a select all that apply question, okay? Or I can put this as a matrix, for instance. Okay, so I'll have two columns wherein you put this as expected, and then the next column would be, let's say, you would call 911, okay, something like that. So a decrease in level of consciousness, worsening headache. So therefore, is there a headache in mild TBI? Yes, because in here, when the patient has a worsening headache, that means, is this still mild? No more. Again, these manifestations here are reasons for the patient to be brought back to the ER. Are we clear? Okay. So dizziness, seizures, abnormal pupillary response, vomiting, irritability, slurred speech, or numbness. Okay, so these are all what again? What are these? Okay. Well, what if you see them? What do we do? Okay, bring them back to the ER. We'll discuss management of spinal cord injuries separately, obviously in a separate chapter. So why again is the patient brought back when they have these manifestations mentioned here? Meaning, is the patient still having mild TBI? It's not mild anymore. It's now moderate or could be severe. So why does this happen though? Why didn't these appear during the admission? What do we call these again? These all resulted from what? See here, why does it say here the occurrence of these symptoms is a red flag indicating need for further intervention? Because what happened to the patient? What did the patient develop while at home? I mentioned this last week. So the patient sustained, let's say, a baseball bat hit to the head, okay? And they didn't lose consciousness, they were fine. Okay, and but then they had the headache, okay, they felt a little groggy, okay, but they said they're fine. They're taken to the ER, CAT scan didn't show any damage. They were sent home, right? With specific instructions, told the family to, okay, when these occur, and they listed them down, if any of these occur, bring them back to the ER. So what did the patient develop while they were at home? I mentioned this last week. That's one of them. So what are these now? Did they sustain them at the time they were in the hospital? So what did they have? Secondary injuries now. Okay. So common causes of secondary injuries are the following. So there's edema, hypotension, respiratory depression, hypoxemia, and even electrolyte imbalances. Okay. So these again resulted from the primary injury. They were not present at the time of the injury, but they later developed. Okay. So we already discussed intracranial pressure and management last week extensively. So we discussed already what is CPP again? What is the concept of CPP? This is the minimum pressure to perfuse brain tissue. Okay. What is the formula again? MAP minus ICP. Okay, very good. So just like hemorrhagic stroke, if the patient has moderate to severe head injury, and then if there are any signs of intracranial bleeding, then it will require surgical evacuation of the hematoma or to stop the bleeding if there is an active bleed. Then remove anything that isn't supposed to be there. Clots, hematomas should be removed, okay, in order to restore normal intracranial pressure. How much again is the head of the bed elevation? Okay, 30 degrees and normal blood volume. So you saw your patient today, Mr. Edward Williams, received IV fluids, right? Okay, to maintain blood pressure. We need to maintain blood volume because these patients, again, are they given a meal? No, these patients will be NPO for a while, for at least 24 or up to 48 hours, depending on the patient's mental status and whether or not they pass the swallow eval. Okay. In magnet hospitals, they do speech evaluation anytime. There is no holiday or weekend in magnet hospital. But for smaller hospitals, including city hospitals, they may only do swallow evals during the week. So if you're admitted on Friday night, then that means you won't be seen until Monday. So what device is this again? To not only monitor ICP, but also drain CSF? Intra what? intraventricular catheter. Okay, so an IVC will be used. This is a quick procedure. So the doctor will simply drill a hole into, they will clip a small patch of hair, okay, to expose the scalp. Then they'll drill a hole into the skull and then insert the intraventricular catheter. We already mentioned this last week. Part of the supportive treatment is not only IV fluids, but also anti-seizure medications. What was that diuretic again used to decrease ICP? Mannitol. Now, steroids may also be administered. For steroids, there's only one steroid used, which is dexamethasone. Okay, we do not use solimedrol, which is methylprednisolone sodium. We use only dexamethasone, okay, to decrease cerebral edema and inflammation. In most cases, if the patient has severe TBI, we keep them sedated. We actually want to induce a coma to reduce metabolic demands of the brain. Therefore, because any brain activity will increase ICP further because it increases my cerebral oxygen demand. So to decrease that, we induce a coma. Actually, we finished this last week and I'm repeating myself. Okay, so brain death, again, we do not have any role here. The doctor will perform tests in order to establish whether or not there is brain death. What is your responsibility again? Who will be calling you? Okay, so OPO will be calling you. Your job is to answer their questions. They won't call you one time. They'll call you every few hours. Okay, so that's just expected for TBI patients since their conditions, especially if it's moderate to severe, the conditions change every few hours. So just be patient. Okay, answer their questions. Okay, when they call, asking about the patient's Glasgow Coma Scale score, what their labs are, what medications are being given. Okay, that's your only role. So a repeat again of the interventions. This was mentioned under stroke. So same interventions. What do we do with the head with bed elevation? 30 degrees. What do we do with oxygenation? A maximize oxygenation. What do we do with the CO2 levels? Okay, keep it normal. Okay, what do we do with the temperature? Okay. We'll discuss end-tidal CO2. These are all related to airway management, meaning when the patient has an artificial airway. When we say artificial airway, that's either an endotracheal tube or a tracheostomy tube. We already discussed GCS. Here are a few differences. So if the patient has little to no GCS deterioration, meaning score is between 13 to 15, that's mild TBI. So that means if it's 9 to 13 or 9 to 12, that's moderate. And then severe, of course, is 8 or less. Now, let me discuss an ominous sign here in vital signs changes. There's something we identify as Cushing's triad. Now, this is nothing to do with Cushing's syndrome or Cushing's disease. Cushing's triad is a trio of vital signs changes that tell us that the patient has increased ICP, but these are actually late signs indicating the patient, yes, they have increased ICP, but it also tells us that death is imminent. Okay, If they don't die, then it probably at least brain death is imminent. Okay, so the three are here. So we got bradycardia, increased blood pressure with a wide pulse pressure. So what is, give me an example of a blood pressure which is systolic hypertension with a wide pulse pressure. What is pulse pressure? The difference between, no, the systolic and diastolic. So what's the normal, what's the normal pulse pressure? It's about 40, right? Okay. So about 40, 30 to 40. Give me an example of a systolic hypertension with a wide pulse pressure. Okay, that's very wide. That's extra wide. Yes, but that's correct. Okay. Plus there has to be bradycardia. Okay. Now, in other authors, what I've noticed is in this author, the Cushing's triad are the following: bradycardia, systolic hypertension, and wide pulse pressure. Okay, those are the three. Now, in other authors, they put the systolic hypertension and the wide pulse pressure together. That's just one. Okay, and then the second is bradycardia. The third is Cheyne-Stokes respirations as the third. But since this author didn't mention Cheyne-Stokes, so we'll just stick with the three. But for the NCLEX, just in case they use another textbook as a reference, Cheyne-Stokes respirations, what is Cheyne-Stokes again? Yeah, deep, rapid, irregular respirations. Okay, so if that's there, then that's one of the triad. All right. So as I mentioned, this is an ominous development. This is most likely that the patient will, right, if they survive, then, but at least their brain will not. Okay, they're basically brain dead. Cheyne-Stokes respirations, deep, rapid, irregular respirations. Any questions about vital signs changes? Okay. So we mentioned already that the patients, this is not only true in head injury, stroke patients also might develop a fever. Okay, the reason for the fever is not only the cerebral ischemia, because what will happen to the patient once you have increased ICP, which is what happens in head injury. So when you have increased ICP, what will you have? Dizziness, headache, right? And what will you do when you have a really bad headache? What do you guys do? I mean, who has migraines here? What happens to you when you have, how do you feel? You feel nauseous, right? Will these patients vomit? And is there any way they can protect their airway here when they vomit after a head injury? So most likely, now don't think of vomiting as like projectile, okay? Like roar. Now they can silently vomit. You know, you've thrown up in your mouth a little bit. That's happening without you noticing it. So they vomit a little bit in their mouth, but then the emesis goes into the lungs. Okay, so the patient is aspirating here without us knowing it. So it's important to monitor the temperature because it's not only because of this, but they may be developing aspiration pneumonia as well, right? And it's very common. So I was just doing my because you're required to do continuing education, right? So I just finished mine, and it said there that 45%, 35 to 45% of stroke patients develop aspiration pneumonia in the first stroke. When they have that first stroke, 35 to 45% of them aspirate. Okay, that's a high number, almost half aspirate. And you already know the implication of aspiration, right? So when you aspirate, what will happen? Pneumonia, and then what happens after pneumonia? Sepsis, and then what happens? Septic shock. So the patient has several problems. Okay, so it's not just the stroke. There's respiratory. I know I skipped over the table earlier, but let me just um, take your attention to this table. Table 63-1. These are the consequences. So system by system consequences after a stroke or after a head injury. So it's not just neuro, but respiratory. Okay. Aspiration is your number one concern. And then there's the heart as well, GI. Now, these patients will have little to no peristalsis. This is what actually leads to the vomiting. Okay. And another reason why we put them NPO. Pupillary reactions, here are the interpretation depending on your pupillary response. If both pupils become fixed and dilated, that means acute injury and intrinsic damage to the brainstem. Okay? So any reaction is good as long as there is a reaction. But if there's no reaction, let's say the pupils are either fixed, meaning they do not constrict, or they're dilated, they do not constrict to light. Okay, so either one is not a good sign. All right? I had a patient like this last week. It was sad because he had his son just talked to him at lunchtime. Yeah, they were talking, and then he said, "Okay, yeah, I'll see you later." Okay, that's what he said. Told his son. And at 1 o'clock, he had a stroke. So that means he finished lunch, right? And at 1 o'clock, he had a stroke. His son came because we called him, and then he came around 3:30, and he was already out. Okay, unresponsive. Then later, over the next 2 days, he spiked the fever, 102, 103, would not go down for about 36 hours. So he had a cooling blanket and everything. So he definitely aspirated. And remember SIADH or diabetes insipidus? Yeah. Okay, so this will occur in head injury. Because these head injury or head trauma was one of the causes named, right? Of SIADH and diabetes insipidus. And which electrolyte are they talking about here? When we say DI and SIADH, okay, sodium. Okay, so hyper or hyponatremia. When appropriate, the patient will receive a NG tube for short-term nutrition. Take note again because what is the effect of the NG tube insertion? What will it do to the patient when you insert anything through the nose? Besides that, what will it do to ICP? Increase ICP. Because what will you do if I put something through your nose? What will you do? Will you breathe or will you hold your breath? Hold your breath, and that increases ICP. Because you're holding your breath also. You can't breathe when you're vomiting, can you? So any activity that causes you to take a deep breath and hold it as in like you're sneezing, coughing, vomiting, because you have to take in the breath, right? Can you vomit if there's no air in your lungs? Impossible. How? Right? So can you cough without air in your lungs? No. If you have to drain the bladder, of course, which one's better, a straight catheterization or a Foley? Straight cath is less harmful. So I don't have to repeat again. We need to keep the temperature as normal as possible. And because these are bedridden patients, so prevent pressure injuries. So pressure injuries can set in minimum 2 hours of no turning. And for coping here, this is not just the patient, but also the family. Okay, this is a life-changing event. They were fine yesterday, and then now they sustained a head injury. Take note again of the, especially with frontal, so just like in stroke, the patient has any frontal lobe involvement in head injury, so expect some emotional lability, so unpredictable behaviors and moods, including sleep disturbances. I'm not testing 63-2. Almost done. Okay, so here's our another set of interventions. It's actually the same things over and over from stroke to earlier, and now there's a chart. So same things, okay, to control ICP. So I know I keep saying 70 to 110, right? So technically, this is what I mean by technically your brain cells are alive if they're 60, but they're dead if they're at 59. So do you want to be 60 to 70 or you want to be 70 to 110? Unless you like living on the edge, okay? You want 60, I want to maintain it at 60. One false move, you go 59, brain cells die. Okay, that should be it because they just keep repeating the same things from here. All right, we'll do spinal cord injury next week.